Hello and good evening to all our viewers for this webinar today. At the outset, I would like to apologize for a slight delay for our starting this program. As you all know, the PCOS Society is conducting such beautiful webinars from all over the world with leaders and experts in the field of PCOS. Today we have Professor Elizabeth Vittorin from the Karolinska Institute of Sweden. She is affiliated to the Department of Reproductive Endocrinology. Her areas of research are sex steroids in reproduction, insulin resistance, diabetes mellitus, type 2 diabetes mellitus, pathophysiology of PCOS. And she's got innumerable publications to her credit in PCOS. So today she's going to talk to us about insulin resistance, how, why, and how to manage it. So let me welcome Professor to this webinar. Thank you so much for coming in today. And I would invite you to give your presentation on insulin resistance, following which we will have a discussion and we will take in questions from our viewers. I hope we have a whole lot of viewers and they're going to be, it's going to be a really interactive session today. Thank you and welcome once again.
Thank you very much for the introductions, Jata. And it's my pleasure to meet with you today, all of you. It's an honor to talk to all of you in India, as I know that your PCOS organization is one of the most active organizations in the world. And currently I serve as president in the International Androgen Excess and PCOS Society. So for me, it's an extra pleasure to do this webinar. And my main research is really PCOS, polycystic ovary syndrome. And just so you know, I'm not a medical doctor, I'm a researcher. So some of the more detailed questions related to how exactly to treat the patients, it's not my side, but I want to discuss the research and also where we are related to evidence today.
Absolutely.
Yes. So today we will talk about metabolic syndrome. That is a very important start of insulin resistance. And what is insulin resistance? Why does it occur? And polycystic ovary syndrome and their metabolic aberrations. And how should we actually diagnose and manage insulin resistance and maybe then focus on PCOS? And you are all aware of the international evidence-based guideline that were launched last year. And there need to be adaptations for each country, but overall it is a very comprehensive summary of all evidence related to the treatment, diagnosis and treatment, and also prevention of polycystic ovary syndrome. I just want to highlight this as well. But first of all, metabolic syndrome. The definition of metabolic syndrome, according to the International Diabetes Federation from 2005, is that it is requiring that they have an enlarged waist circumference. And for men, it is above 94 centimeters, and for women, it's above 80 centimeters. And also here, it's important to check the ethnicity because there might be variation depending on from where the person are. And then, so it is always enlarged waist circumference and at least 2 out of the following criteria. Either high triglycerides levels circulating, low high density lipoprotein cholesterol, high blood pressure or blood pressure over 130 and 85, or that they are medicated for high blood pressure, and a fasting plasma glucose above 5.6. So if they have 3 criteria, the waist circumference plus 2, then you have metabolic syndrome. The different components of metabolic syndrome are each of them important diseases. Abdominal obesity, this is the shape of a more male-like abdominal obesity. But if we look at the woman, it's also that they can have a more male-like obesity, that it is more located around the umbilicus. Whereas this is more the female, the pear shape of obesity, or this is not obesity, but this, if you measure the waist circumference, that will not be increased. The insulin resistance in diabetes type 2 is one very prominent component of metabolic syndrome. You have the increase in the fasting glucose, you have a decrease in glucose tolerance, and or insulin resistance. I will come back to these features later on and what they are in specific terms. Also dyslipidemia with increase in triglycerides. The storage of triglycerides in the adipose tissue is compromised, so it's not able to store, so there is a leakage of triglycerides. And again, the lower levels of HDL and higher level of LDL and the hypertension. So what is insulin resistance then? Yeah, insulin resistance is really then you have when normal insulin concentration, it does not give enough stimuli for the peripheral tissues. So what happens immediately then is that the beta cells in the pancreas, it start to secrete more insulin. So you get a compensatory hyperinsulinemia. Very often when you measure glucose levels, which is the most easy, cheap, and easy to do in the clinic, they can have a normal glucose level or slightly increased. But if you measure the insulin, then it's definitely higher. So they have a compensatory hyperinsulinemia. And if it's continuing, then in the end, it might happen that the beta cells they are not able to produce enough insulin. And then you get the hyperglycemia as well. And this is really, it's a gliding scale from pre-diabetes to a type 2 diabetes. And as many of you know, there are several indications that type 2 diabetes is like PCOS have many different components also, but we will not talk about that today. So insulin resistance is really that you have an impaired glucose metabolism and tolerance, and an abnormal response if you do an oral glucose tolerance test, which you do in the clinic. And you also have a decrease in the insulin-mediated glucose clearance or suppression of endogenous glucose production if you do an euglycemic hyperinsulinemic clamp test. And just briefly, an euglycemic hyperinsulinemic clamp is something that it's rarely done in clinic. It's more or less an research tool. But it is the absolutely gold standard for measure insulin sensitivity or insulin resistance. And when you read studies and they have used this, is that they give an first and high bolus dose of insulin, and thereafter a continuous infusion of insulin. And at the same time, a glucose solution is administered to the patient. And every 5 minutes is the blood glucose level taken. And they are trying to keep a constant glucose level by increasing the infusion or decreasing the infusion of glucose. So if a person is very sensitive, they can have high glucose infusion rate. And if it is insulin resistance, they have very low glucose infusion rate. So that is how it's interpreted. So if we look into the peripheral tissue, what happens in the tissues, and what does insulin first of all do in the different tissues? Yeah, what insulin do in this symbolize the liver. Yeah, insulin binds to the receptors, the insulin receptor substrate 1 and 2, and the receptor and activate insulin receptor 1 and 2, and PI3 kinases and ACT to stimulate the glycogen synthase, and glucose can be stored as glycogen, so you have an increased glycogenesis. It also inhibits the gluconeogenesis, the production of new glucose. And in the skeletal muscle, what insulin do here is that they stimulate the insulin receptor and the insulin receptor substrate 1 and 2 to activate the GLUT4 to translocate to the membrane, so glucose is taken up into the cells. And in the adipose tissues, insulin stimulated triglyceride synthesis, and it stores triglycerides and it inhibits the lipase, so it's not releasing that much free fatty acid. But as soon as you become insulin resistant, then the cells are not responding to insulin in the same way. So the glycogen synthesis and storage of glucose in the cells are less. So you have more circulating glucose. The gluconeogenesis is increasing, and in the muscle, the GLUT4 translocation is decreased. You have less glucose uptake and glycogen synthesis and glucose oxidation. And in the adipose tissue, you always also have the negative effects on lipogenesis, lipolysis, and increasing triglycerides and free fatty acids. And this here, it can be many individual variations. Of course, the skeletal muscle is a very important organ regulating the glucose homeostasis, as it stands for about 85% of all the glucose uptake. But the liver and adipose tissue and also other tissues are of importance also for glucose homeostasis. So insulin resistance is very tightly linked to dyslipidemia also. And as insulin resistance increases lipolysis in the adipocytes, it also increases the free fatty acids. And in the liver, the free fatty acid serves as a substrate for the synthesis of triglycerides and apolipoprotein B. And this increases the VLDL, very low density lipoprotein. That is transferred either to the low density LDL or to the high density LDL. And this triglycerides enriched LDL increase the hepatic lipase and cleared rapidly from the circulation. And this is that you get the lower, why you get the lower HDL, the good cholesterol, so to say. So dyslipidemia is also associated with insulin resistance. And we have more of this very low density lipoprotein secreted by the liver. And it's also closely related to oxidative stress and endothelial dysfunction. So why do we get insulin resistance and metabolic syndrome? Yeah, I would say that very much is related to inactivity. We have a more inactive lifestyle in general. Many of the type of working habits are that they are sitting, and also the physical activity. Those who do physical activity today, they do it quite a lot, but the vast majority are not doing any physical activity and in a big way. So we know that the lifestyle factors are contributing to all the factors related to metabolic syndrome and insulin resistance. We know also that genetic factors are of importance and may stress and contribute to the development of insulin resistance. But also factors like intrauterine environment. This is something that my group is very interested to investigate and study. That we investigate how the growing fetus are affected by both diet-induced obesity and by androgen exposure. I will briefly come back to that later. So that was a first and short introduction about insulin resistance and metabolic syndrome. And now I will come in a bit on polycystic ovary syndrome, that I assume that all of you are well aware about, that it is the absolutely most common endocrine and metabolic disorder, and it affects up to 70% of all women in reproductive age. This numbers varies. It varies very much depending on how you diagnose the women. But if you have 2 out of these 3 criteria with hyperandrogenism, clinical or biochemical, oligoanovulation, or polycystic ovarian morphology, 2 out of these 3 criteria, you have polycystic ovary syndrome. And if you have polycystic ovary syndrome, we know that they are at an increased risk to have several different disorders like subfertility. They are not infertile. Many metabolic disorders, including insulin resistance, are much more likely to develop type 2 diabetes and cardiovascular disease. They are also much more likely to develop psychiatric disorders like anxiety and depression, but also autism spectrum disorders, ADHD, and other psychiatric disorders has been shown to be much more prevalent in women with PCOS and also in their offspring. And I think you have had a webinar with Anuja Dokras already discussing the psychiatric and health-related quality of life of women with PCOS. And we know also that women with PCOS are likely to be obese, and obesity makes all these factors worse. So looking at the metabolic factors, in this relatively recent review article, they took up the ethnicity, obesity, and prevalence of impaired glucose tolerance and type 2 diabetes in PCOS in a systematic review and meta-analysis that was done in relation to the big international guidelines. It definitely showed that there is an increased prevalence of impaired glucose tolerance and type 2 diabetes in women with PCOS. And I would like to stress here that it is also independent of obesity, although obesity makes everything worse. And also the normal weight or lean women with PCOS are at an increased risk of developing metabolic disorders. And the same is for cardiovascular disease. And women with PCOS have a higher cardiovascular disease event rate, including hypertension and dyslipidemia. And this study is from a Danish register, nationwide population study, where they, by using the medical register, so getting a large number of women, got this results. So how should we diagnose insulin resistance in PCOS? This slide or text is coming from the international evidence-based guidelines. So this is a recommendation summary. I just took it out. And in the context of diagnosis, we recognize that PCOS is an insulin resistance and metabolic disorders. However, tests for insulin resistance lack accuracy and should not be incorporated into the diagnostic criteria for PCOS at this time. And I think this is something that we also need to stress. We know that it is very common, but according to the guidelines, it's nothing that should be incorporated in the diagnostic feature. However, we know that they are at an increased risk, so they should be screened, definitely. It's also highlighted that there are ethnic variations, and increased central adiposity and insulin resistance, diabetes, and metabolic risk and acanthosis nigrans in Southeast Asians and indigenous Australians is more common. So it's also important, of course, to look into if there are differences depending on where you live. So, which is the most effective tool and method to assess risk of type 2 diabetes? Yeah, when models were considered for age, BMI, fasting glucose, 2-hour glucose on oral glucose tolerance test, and circulating triglycerides were the best predictors. So the oral glucose tolerance test, which I think if you're working in the area are doing routinely, is the test to be used together with triglycerides levels to predict whether women are likely to develop type 2 diabetes or if they have type 2 diabetes and insulin resistance. So a little bit from my own research also. What we did here were that we phenotyped women with polycystic ovary syndrome very carefully, and we performed euglycemic hyperinsulinemic clamp, the clamp that I told you about before. And if you have a high glucose infusion rate or disposal rate, that is the same thing, then you are more insulin sensitive. And you can see here that women with PCOS, when they were matched for age, weight, and BMI, have a lower insulin sensitivity. They are insulin resistant. We further characterized these women. I already told you that metabolic syndrome, the waistline and the waist circumference is a very important measure. Of course, it is extremely cheap and quick and fast to just measure waist circumference. But what other tools do we have to actually measure this? The adipose tissue or abdominal obesity. Yeah, we have the MRI, we have the CT or ultrasound, but we also have DEXA. But this is an example of how it could look like when you do an MRI. And this is a picture from a woman with a BMI around 39. And you see the subcutaneous adipose tissue here, and everything in here is the intra-abdominal or visceral adipose tissue. And by an algorithm, we were able to quantify whether they have more total adipose tissue, or if they have more subcutaneous adipose tissue, or more visceral adipose tissue. It is believed that the visceral adipose tissue is the more severe adipose tissue, which contribute to insulin resistance also. And here we did not see, and when we pulled all women together, that we did MRI and compare with controls, we did not see a significant difference in adipose tissue distribution. However, when we divided the women in normal weight, so these two graphs are normal weight, PCOS and controls, and these graphs are overweight and obese. TAT is total adipose tissue, SAT is subcutaneous adipose tissue, and this is visceral adipose tissue. And you can see here that the normal weight and the lean women with PCOS, they have more total adipose tissue and more visceral adipose tissue. They have slightly more also of the subcutaneous adipose tissue, indicating that, I would say this really indicates when a woman become overweight or obese, both women with and without PCOS accumulate fat. We next went on to look at the adipocytes, and the adipocyte size is very important in the metabolic health. And what I just show you here, it is how much an adipocyte can vary in the body in size. And we know that if you have large adipocytes, hypertrophic adipocytes, it is strongly linked to insulin resistance, hypertension, dyslipidemia, and is a predictor for type 2 diabetes. And likely they have also altered adipokine secretion. We collected adipose tissue in these women that we also had done clamp and an MRI on. And I think you can see here that they have larger adipocytes compared to a control woman. And these are both normal weight. So they have significantly more or larger adipocytes. And that is how it can be looked like. And here we did not see an infiltration of the macrophages, and we could not see that they have an increase in inflammatory markers, which has been proposed. But we wanted to know which predictor or what explaining their insulin resistance. And when putting all together in a statistical model, we found that the adipocyte size, together with circulating adiponectin and waist circumference, they are the best or the strongest factor actually explaining their insulin resistance or insulin sensitivity. So if you have lower glucose disposal rate, you have larger adipocytes. But the very simple measure of an increased waist is a very good measure. So we also found in the same population that they have increasing coagulation and fibrinolytic disturbances, which also is linked to the insulin resistance. And we all have also done transcriptomic and DNA methylation analysis. Global DNA and gene expression analysis demonstrate that women with polycystic ovary syndrome have multiple epigenetic and transcriptional changes in both subcutaneous adipose tissue and in skeletal muscle that may be relevant for development of disease. So the question is, how should we manage insulin resistance in polycystic ovary syndrome? Yeah, we know that the general recommendation of treatment of metabolic syndrome is very like the same as for insulin resistance. The first choice of treatment is lifestyle management or lifestyle program with diet, weight, focusing on weight reduction. There are no diets that have been proven to be more effective than any other diet. And of course, increasing the amount of physical activity and exercise. There are a number of pharmacological treatments for both blood pressure, insulin resistance. Metformin, of course, is very common. The statins for dyslipidemia and other anti-obesity drugs. if the woman is have overt obesity, gastric bypass surgery for obesity is the treatment of choice. So what is the effectiveness of lifestyle intervention? Yeah, the evidence, there is evidence to say that lifestyle intervention should be multi-component. So they should include both diet and exercise, but also behavioral strategies. So maybe cognitive behavioral therapy, or that they actually need guidance to follow and to be able to continue and get into an healthy lifestyle. So, and the recommendation is that they, especially those with excessive weight, and it is very much focusing on weight reduction. But just increasing the physical exercise and activity can also be very helpful. And there are exercise interventions, and I would not read this because you have the presentation. But in the guidelines, you find direct guidance how you should train. I would just like to stress that the degree of evidence and how to do it's not in the highest evidence. Metformin, is metformin alone or in combination effective for management of hormonal and clinical PCOS features and weight in adolescents and adults? There is there are evidence that metformin, in addition to lifestyle, could be recommended to adult women with PCOS for the treatment of weight and hormonal and metabolic outcomes. And it should be considered in adult women with PCOS if there is a BMI over 25. And again, I will not read this throughout because you have it here. What I would like to bring up, and now I'm soon in the end here, are there alternative approaches to exercise? And my group has investigated also the effect of non-pharmacological approaches, both exercise, but also acupuncture with electrical stimulation causing muscle contractions. So the question is, can acupuncture regulate glucose homeostasis in women with PCOS? And as you see in the cartoon here, needles were placed in the abdominal muscles and in large muscle, vastus lateralis, and in the lower leg. And they were stimulated with a low frequency, giving muscle contractions with an intensity as high as possible without pain and discomfort. I would like to start a movie here. I will see if I can manage to do that. I'm sorry. I know that I have a movie. Yeah. May I? No, I skipped the movie. It was just, I wanted to show you how it actually looked like. But what we did show here, that just giving a single bout of low frequency electroacupuncture increased glucose infusion rate. The white bars here are women without PCOS, and the purple are women with PCOS. This is during an euglycemic hyperinsulinemic clamp, and you can see that the PCOS women have a lower glucose infusion rate. They are insulin resistant. During stimulation, you can see a slight increase in glucose infusion rate in both PCOS and in non-PCOS. After post-stimulation, you can see that the glucose infusion rate is significantly increased in both women without and with polycystic ovary syndrome. And this was heavily and highlighted when we published this in FACET journal. And they highlighted that electroacupuncture may improve regulation of blood sugar in overweight and obese women. And I would stress that especially in women that have difficulties in doing exercise to the amount that is needed, this can be an alternative. We also wanted to know the mechanism behind this. So in rodents, we did exactly the same, the euglycemic hyperinsulinemic clamp. And first we went to steady state. It's the same as the baseline here. And then we place the acupuncture needles and we stimulate, and you can see the increase in glucose infusion rate, exactly as we see in the women. And we believe that the effect of low frequency electrical stimulation, at least in part, is mediated via the autonomic nervous system. So we administrated propranolol on phenethylamines. We blocked both the beta adrenergic and alpha adrenergic receptors. And as you can see, the effect was completely gone by the stimulation when we did this. So, yeah, that way I've already. Next, what we did was that we gave the PCOS women 5 weeks of treatment 3 times a week. And we measure HbA1c. As you can see, it is significantly decreased. The clamp was not significantly improved. However, the HOMA, insulin resistant index, was decreased. You have to remember this was a very few patients in this preliminary study. It was not this study was a basis to continue to a new study. We also measured circulating and subcutaneous adipose tissue concentrations of androgens, and that was measured with a gas chromatography and mass spectrometry, so a very sensitive method. And as you can see here, circulating testosterone after 5 weeks of treatment was significantly decreased. I'm sorry. Exactly the same thing happened also in the subcutaneous adipose tissue. And the same for DHT. Circulating level was significantly decreased, and also adipose tissue concentrations. So this was the first study to demonstrate that actually 5 weeks of low frequency electroacupuncture improves and decrease circulating HbA1c and androgens in overweight women with polycystic ovary syndrome, an effect that at least in part may be mediated via the decrease in adipose tissue androgen concentrations and adipose tissue sympathetic activity. What we do currently is that we perform an randomized controlled trial that we compare acupuncture plus lifestyle intervention, and the lifestyle intervention is very mild. They are told that they should eat healthy and do exercise, nothing else. And then they are randomized to metformin and lifestyle or lifestyle alone. So this is a head-to-head trial with a treatment of choice that is recommended in the guidelines to see if acupuncture, at least in part, can give the same effect as metformin treatment. And last but not least, I would like to thank my group. They are the one who really do all the work, and of course all my collaborators around the world that is not mentioned here in my slide. So thank you for listening.
Thank you very much, Professor.
I'm sorry, I need...
Am I there?
So?
Yes.
I'm here? Yes.
Yeah. So thank you very much. That was an excellent lecture,
Thank
especially
you.
for clinicians for whom, understanding insulin resistance is always so complicated. And you added so many new dimensions like the adipocytes and the size of the adipocytes, in which really I didn't know much about that at all. And about the possibility of electroacupuncture, that was something new, with the
Mhm.
possibility of doing acupuncture having an impact on glucose metabolism and homeostasis. That was really great.
Yes.
So I think we can now open our discussion
Yeah.
to the audience, and hopefully we'll have some questions from the audience. Meanwhile, I am coming in with a couple of questions that I thought I will, open up as a discussion. Can you see my presentation?
Yes. Yeah.
Okay. So insulin resistance is nothing new for us and as Indians. We are the diabetic capital of the world.
Yeah. I know.
We are known as the thin fat Asian Indian. We have very high body fat, very high visceral fat, abnormal waist circumference, and profoundly high insulin resistance. And the cause of this phenotype is probably new. I mean, environment and lifestyle. The Indian people have adopted the Western food and Western
Mm.
lifestyle in a big way. Maybe that is one of the cause, or maybe epigenetic or genotype. Really, one doesn't know what the cause is. But I wanted to draw your attention to some of our published data, wherein we have shown that in a group of PCOS women, the prevalence of metabolic syndrome was as high as 35 to 39%. In
Mm.
the lean PCOS also, uh, sec, I don't know why this is,
Mhm.
I don't seem to be able to run my, is my PPT,
It's try to go back to the previous one.
no, it's stuck.
Mm.
Let me stop share and do it again. Yeah, so can you see that now?
Yeah. Yeah.
Yeah, yeah, sorry for that. So we also showed that in the lean PCOS women,
Mm.
uh, the prevalence of metabolic syndrome was as high as 11.6. And the
Mm.
normal weight lean women had an abnormal waist circumference in as high as 60-65% of the women.
Mm.
And in a publication in the ACOG journal with the Anuja Dokra's group, in which we had shown racial and ethnic differences in the prevalence of metabolic syndrome, in which 5 countries contributed data: United States, India, Brazil, Finland, and Norway. Over there, you'll be surprised to see that Indian women, although were much younger,
Oh, that was. Mm.
they were much younger, and their BMIs were the lowest. Yet, when compared to white Americans, they had a six-fold higher chances of, you know, um, metabolic syndrome when the BMI and age was controlled. And this was driven by a very elevated fasting glucose. So
Okay.
we as an ethnic group, we have a huge problem with insulin resistance,
Yeah.
diabetes, gestational diabetes, and in PCOS, it is like really prevalent.
Mm.
So about insulin resistance, when you were talking about that, I always think that is it true that all PCOS women have some degree of insulin resistance at cellular level? Does it? What I'm trying to say is, does it mean that if somebody has PCOS, she has insulin resistance? Period.
Period. Yeah. Of course, it's a very relevant question, and I don't think everyone has it, but as as we have, as I demonstrated here before, in our very limited population, but they are extremely well characterized. Also, the normal weight women had a more aberrant adipose tissue morphology,
Right.
larger adipocytes. They also, when we looked at we did the DNA methylation and transcriptomic analysis. It is also more aberrant. We never look into the individual person here, I have to say, but I would say still it's not very many, but it's still significant, which means that it is quite a strong effect. And it has been repeated several times now also. So I believe that women with PCOS are at an increased risk, yes, also if they are normal weight, also at cellular level have an impaired function. In our research, in our animal research, we use different androgenized models.
Correct.
So when we expose a mice for testosterone or DHT, for example, at the very early stage, they become obese, and later on they become insulin resistant. We also have, and so what I would like to say is that androgen are a very strong inflator of adipose tissue function and distribution. If it is the androgens or if it is the androgens that affecting the cells and making the obesity, that
or egg first story.
We don't know.
We don't know that. Correct.
No.
But
no.
somehow insulin resistance has never been included as a diagnostic criteria. It has never been
No.
included.
And obesity is not, BMI is not a diagnostic criteria either.
Correct.
Which is, it is, it is, I know that there were, I was not in that group, but it has been discussed, but no, it is not.
So we have a question from one of our viewers, Ruchi Bhargava. She was asking if we need to document insulin resistance for diagnosis of PCOS. I guess you already made that clear, that we really do not need to do that, because we do not have any proper means of testing for insulin resistance, right?
No, but if we go to the guidelines, if a woman has a BMI over 25, we should maybe screen them, but it's not for the diagnosis, but they are at an increased risk, but not for diagnosis of PCOS, as we stated.
So we to look at the metabolic risks.
Yeah, and especially now, if we see to your ethnicity, it seems that also in the normal weight women with PCOS in India,
yes,
they are at an increased risk.
To test even for lean women.
Yeah,
and they do have a family history.
Yeah, and of course it would be really great. Now you have already done this study that you combine data, but also to collect larger populations, so you really can get them. Maybe there might be individual variations in the different areas in India too. We don't know.
We don't know that.
No.
We don't know that. And we have another question from Dr. Reena. She asks, if obesity is important for insulin resistance, then why lean PCOS have worse metabolic problems? I would not
say that the lean has worse. No, but maybe I was not clear enough. But it is my interpretation with this is that when a woman, even though if they do not have PCOS, when they become obese, they also got metabolic problems.
Exactly.
But they are more severe in PCOS.
Exactly.
But an unpublished study, and that is the reason why I didn't take it up here in my presentation, that we have screened 298 women with severe obesity. So they were referred to an obesity unit in Sweden. And we screened them whether they have PCOS or not, the diagnosis, and whether they have metabolic syndrome or not, and whether there is a difference. And the prevalence of PCOS, it was as high as 25.6% in this obese population.
Correct.
So when a woman becomes that obese, the prevalence increased furthermore.
Yeah.
Yeah,
They increase the insulin resistance.
Yeah, but the prevalence of metabolic syndrome, there were no difference.
Correct.
Yeah. Mm.
And then we have another question from Dr. Usha Rani, who asks about metformin and adolescents. Again, about adolescent PCOS, we really have many doubts about how to manage them. And she was asking about metformin, how long it should be given. But I guess that's a very clinical question.
Yeah, I prefer not to go into those clinical questions. I'm really sorry for that, but it feels wrong to do that.
Yeah.
But it's relatively detailed described in the guidelines. So I really recommend you to go into the guidelines, and also if you do not find it there, you have all the references.
Correct.
That is supporting
I may answer her
the
question.
guideline.
Metformin has been studied maximum for about a year or two in obese adolescents. And whenever we want to prescribe more, we have to keep following up the patient, calling her back, looking at her, what changes she's done, what weight she's lost, and accordingly decide whether we can give it or not. Although it's going to be a pretty safe drug.
Yeah.
And then we have another question. Should we use OGTT or HOMA for testing insulin resistance? I think that was pretty clear. You made it.
As HOMA is a lazy dog test, and it is not the best. So oral glucose tolerance test, together with triglycerides, is the best predictor. That is really what the evidence-based guidelines also says. So it is OGTT.
And it's much simpler also.
Of course, HOMA is easier. Because you just take fasting levels.
Yeah.
So if you have a very big cohort, HOMA can be used, of course. But if you in the clinic, it's better to do the oral glucose tolerance test, definitely.
Correct. And insulin, serum insulin levels are also not very accurate when we test them. So that's one of the problems with this thing.
Yeah.
So I think OGTT should be the answer. And then we have another question about any controversies regarding using metformin without testing for insulin resistance.
You're thinking of more reproductive and to actually modulate the hormonal levels in that terms. Yeah. Again, it's a very clinical question, for example, in the study that I mentioned in the end, that the randomized control study, that we compare low frequency acupuncture and lifestyle with metformin and lifestyle and just lifestyle. These women, they are to be, we just take a fasting insulin and glucose and measure HOMA. So there we start to treat them for 4 months without really saying that they have an insulin resistance, and then we look at the outcome. But I have no data there. I'm also involved in quite a number of studies in China that we have measured or looked at metformin before ovulation induction.
Correct.
To see if it is improving, and again the results is not crystal clear, and it's still something that is debated whether it should be used and so on. So
right. And there's another interesting question from Dr. Shobna from Bhubaneswar, where I stay. She's asking about the role of myoinositol. Have you not had any studies? I mean, myoinositol is also an insulin sensitizer. Have you had any studies or any experience about myoinositol versus metformin? Do you think it could work, although the current data is not sufficient? What do you think of myoinositol?
Yeah, yeah. Again, we haven't tested it, so I have no experience and I have no data to show.
Yeah,
The reason why we selected to compare with metformin, because that is the, how to say, the standard as used
that's
in
the
clinic.
time. Yeah, yeah,
Yeah, and so we didn't want to take two new treatments, put them together. We
mhm,
wanted to have the treatments that are most commonly used,
yeah,
lifestyle and metformin, and that is also given in the guidelines. So we wanted to keep with that. So the next step might be to, depending on the results of these, might be to compare that. So I completely agree. We definitely need to do much
more
more
studies. Yeah,
research, and I think a very strong thing, even though the effectiveness of the insulin resistance symptoms are the same, it's also about side effects. There might be less side
less
effects.
side effects with myons. Absolutely,
Yeah,
absolutely. Then,
and
Dr.
that I just want to stress that, and that is also something that we believe in when we giving acupuncture. I think it's very hard to beat a drug with an
Yeah,
acupuncture treatment,
yeah,
but
yeah,
um, at least it would be very similar results on insulin sensitivity, but
yeah.
less side effects.
Correct, correct. But somehow, we prescribe metformin a lot, and
Mm.
I think collectively, many of us clinicians have a feeling metformin doesn't have too many side effects in our patients. They're quite all right, and they tolerate metformin pretty well. So anyway, we have another question from Dr. Kumudini. She's asking if there's any relationship between leptin and insulin resistance.
Um, yes, it's a very good question. Leptin is secreted from the adipocytes, and it's one of the first adipokines, and the obesity researchers in the mid 90s were super happy because they thought that now we have found the drug to really cure obesity. But then it turns out that when a person becomes obese, they also become insulin
Yes,
resistant.
correct.
Yeah, so and there is an relation with increased leptin and insulin resistance.
Yeah,
However, I would say there are other adipokines like adiponectin that is much stronger linked to insulin resistance compared to
left.
leptin. So I would say adiponectin is one of the strongest factor, as I said, explaining insulin resistance. So if you have low adiponectin, you're more likely to develop insulin resistance.
So from adipocytes, I remembered from your presentation. Actually, I didn't understand too much about the hypertrophy and hyperplasia.
Hyperplasia,
Yeah. So I was,
yeah.
is there something about PCOS women and their adipocytes and their adipocyte stem cells that may be committed in a different way? What I'm trying to ask, is there any truth in the fact that PCOS women have more difficulty in losing weight compared to others?
Mm.
Would love to
Also,
say that.
very, 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 very good question.
Yeah.
First of all, to answer your first question, what we have done in both in our mice studies and what we are currently doing now in women with PCOS, when we collect adipose tissue, we isolate adipose stem cells, and so we just have a stroma vascular fraction, and then we stimulate the cells to start to differentiate into mature adipocytes, and we take them at different stages because there are some studies that you have done just in vitro adding testosterone to healthy adipocytes or adipose stem cell, indicating that testosterone impair or they get a very rapid differentiation, and then it slows down, so it's they're getting an impaired adipogenesis, and that has been linked to increase in lipotoxicity and metabolic inflexibility and also insulin resistance. However, it's much more to do here. It
Yeah, it's not
takes
as
so
simple.
long time to do this, and we currently trying to understand the mechanism. But now we have done it in several different animal models,
Yeah.
and it seems that they have an acceleration, so to say, in the differentiation that is then slowing down.
So
So there
maybe
is an impaired.
understanding these adipocyte function and stem cell commitment could also help us understand how lean PCOS are different from
Yes,
these ones, right?
yes, yes, yeah. We have a very interesting mice model that overexpress nerve growth factor in the ovaries, and this mice model it becomes hyperandrogenic, and they have a polycystic ovarian morphology, like I would say it's mice. But interesting, they are not overweight or they do not weigh more, but they accumulate more fat. They get
Correct.
larger fat cells. They
Yeah,
have also an impaired adipogenesis and differentiation process.
absolutely.
And this model also have an high activity in the sympathetic nervous system, which is all linked to um, many of the metabolic impairment that women with PCOS have too.
Absolutely. So we
Yeah.
have another question is that what kind of, yeah, so there's a question about OGTT, whether it should be done with 75 or 100 gram glucose. I think that's pretty clear. It should be 75-gram glucose tolerance test, right?
Yes. Yes.
Yeah. And then Rina also asks, what kind of lifestyle changes would you recommend to lean PCOS? Because lean people think they're lean, so they really don't need to get into any kind of a exercise and all that, and diet habits and all that. I think that's a real misnomer. But what would your advice be? What lifestyle changes for lean PCOS?
Yeah, the major lifestyle changes, of course, they need a guidance or and education what to eat. If they eat healthy or not, you can be lean and eat crap and
Exactly.
fast food and so on. That is of course number one, that you really need to eat and very balanced healthy diet. And again, I do not want to go into a particular diet because, from my perspective, I don't think there is any diet that have been shown to be better than another one. More than it should be, it has to be balanced.
Mhm.
And then, of course, increase the physical activity and exercise. And usually, I differ between activity and exercise,
Yeah.
because activity, the physical activity, it is this that if they have a sitting work, they can use a standing table, so they actually stand up and work. They do take the stairs instead of taking the elevator. They walk instead of taking the bus or car and so on to work or school.
Yeah.
So it is really that type of lifestyle changes, always activity. And then, of course, also to do regular exercise. And
Yeah.
regular exercise has to be at least 3 times a week. And
Yeah.
again, that is also given in the evidence-based guideline. And
Absolutely.
I would say that it's not many women, either lean or obese, that do that amount of activity or exercise.
Yeah. And would you not agree that in practice we often see that today's lean is actually tomorrow's obese? So
Yes.
if they don't take care of themselves, they are going to become obese. And usually the leaner ones are younger ones that we see. I mean, this is just practically what we see uh,
Yeah.
in our practice.
Yeah.
Also, you mentioned that dyslipidemias are associated with insulin resistance, and you showed nicely the pathway as to how that can happen. Also, I think I would like to draw your attention to the fact that when we test our patients here, PCOS patients, like they're really having very low LDL.
Mm.
I mean, I
Low,
think
low, low HDL. Yes.
HDL, I'm sorry, HDL. And in our study, in the multiracial study that we reported, we, I think, had 99% almost of
Mm.
PCOS women with low HDL. Do you see like that? I mean, it was quite unexplainable. I asked many of our colleagues and all that. Most of us see a very low HDL in our women in India. Do you think it? Do you see the same?
No, actually, we do not see the same. And actually, the study you just showed before, together with Esther Vanki and
Yes.
Anuja,
Yes.
our cohort was included in that study
Okay.
from the beginning. But
Okay.
Anuja decided to actually take it out because it was a pool of from several studies, not just mine,
Okay.
and they were relatively healthy related to lipids.
Okay.
And we didn't know why, and they thought it was a kind of selection bias and so on.
Correct.
But what we see very often in our study, I would say in all my studies, it's not the LDH or HDL or LDL that is significantly different. It's triglycerides. It's circulating triglycerides. And as I don't know, and for me that is very logic, as we can also, as we in most of our studies we also phenotype their fat cells, and we can directly see that they cannot store triglycerids in the right amount.
High triglycerides also, but it's really abnormal the fact that almost all of them have low.
Yeah. Mm.
Yeah.
And I think that is once again a reason why it would be where it is very important that you try to collect a large amount of data in your population to really show that this is the fact, because I think here it can be ethnic variations.
Yeah, quite right. We have another question. It's something about arm thickness in obesity. I think fat thickness, is that also a valid way to test body fat?
Yes, to measure the arm thickness, and it can also be used in the tight. We have never used it, and I haven't went into the literature in detail, but I know that some people do that, and there are one or two studies indicating that it is as good as measuring waist circumference.
Yeah.
But I would stress that I think it's better that we use waist circumference as everyone do it. Yeah. It is an international standard to measure and also diagnose metabolic syndromes.
Yeah.
And it's better to do the same as everyone else, and then you can compare your results and so on.
In fact, we've also seen papers that show neck circumference.
Yeah. Yeah, and of course, if you have acanthosis nigrans and you also have an accumulation of like in buffalo ham.
I also wanted to draw your attention to another fact. Acanthosis nigricans is like so prevalent in our.
Yeah, I know.
It's amazing.
And it's not. Yeah.
And it doesn't correlate with equally higher impaired glucose tolerance.
Mm-hmm.
So, like, I see a patient and she has severe acanthosis, the neck, the elbow, and everywhere. And I'm sure that she has a high blood glucose, but it doesn't always correlate.
No.
Do you think
is it a timing?
The timing?
Is it a timing? She's too young, so it just will wait a half year or a year or two.
Then it
and then she develop it.
Maybe.
Yeah. I don't know. I thought it was actually going hand in hand, but apparently not.
It doesn't happen.
Mm-hmm.
And about your acupuncture, that was also a very interesting study. I thought, how did you get that idea? Because there have been many publications, I think also from the Nordic countries, about IVF outcome and acupuncture, stress and acupuncture related to IVF outcome. And those studies really haven't held up to supporting acupuncture.
No.
So how did you get this idea?
A very long story. Yeah, long story short, we were the first who actually did acupuncture in IVF, and I had an interest in acupuncture for a long time in my first training. So I actually gave acupuncture, And I wanted to do a project, and then a professor in physiology, he said that I have been contacted by 2 IVF doctors and asking if acupuncture can improve pregnancy outcome for IVF.
Mm-hmm.
And this was about 1992 or something like that.
Yeah.
And he said, I have no idea.
Mm-hmm.
And the reason why they asked him were because he had an interest in acupuncture, mechanistic opioids, and it had been shown that acupuncture can be used as a pain relieving method and so on. And we decided actually to do a study because they, at that time point, it was also demonstrated that if you have an high pulsatility index in uterine arteries,
Mm-hmm.
when you do an embryo transfer,
Okay.
the success rate was very low.
Correct.
So as you know, aspirin is used quite a lot to improve the blood flow and so on. So we did a study that we first identified women with a high pulsatility index, a low blood flow, and then we treated them for 4 weeks prior they did the embryo transfer. This was an uncontrolled study. They were tested several times,
Mm-hmm.
and we found that 4 weeks of acupuncture lowered the pulsatility index and increased the blood flow. That was published in Human Reproduction in 1996, and it was nothing to do with the pregnancy outcome. And after that, it was also at the same time as we did this, they were interested in to investigate, can acupuncture be used as a pain relieving mechanism when we do the oocyte aspiration. So we did acupuncture in women with either they got conventional pain relief. In Sweden, they just do it giving pain relief, and acupuncture. And we found
at the same time as when they were undergoing pickup?
Oocyte aspiration. So they gave acupuncture instead of sedatives.
Okay.
And they did a paracervical blockade.
Mm-hmm.
and acupuncture, and we found that it was good as an pain relieving method. Mm-hmm. And in the first study, we had 75 women in each group, 150 patients in total. We found an increase in pregnancy outcome in the acupuncture group. However, and that was also published in Human Reproduction, but we also wrote very clearly this study was not. The power was not calculated for pregnancy outcome. It was calculated for the pain outcome.
Okay.
And we redid that study, mm-hmm. and with a double number of patients, and found that there were no difference. And after that, I think there are 30 different studies giving acupuncture before and after embryo transfer, and so on. And honestly, we stopped there because we thought that no, there is nothing there. It can be used as a pain relieving method, but not as to improve. I do not believe that it can improve pregnancy outcome.
Yeah.
But I just want to say one more thing.
Yeah.
And it is for the Pcos women. We have seen that it can lower circulating testosterone also, and stimulate ovulation induction.
Correct. So so even in our country, we have plenty of yoga.
Yeah.
And there's so many publications now coming in.
Yeah.
I looked over before talking to you. I thought this would be a good idea. That many publications about role of yoga in type 2 diabetes. There's a meta-analysis, and from different Asian countries, not just India.
No.
So maybe one should be doing more studies to kind of see if alternative medicine and options like acupuncture and yoga in India could have some future in improving insulin resistance.
Yeah, I definitely think so, and I think also as for all chronic and long-term
Yes.
diseases. It is very difficult to be on one and the same treatment for a very long time, and it also holds for pharmacological treatment. So you need to maybe vary
Yeah.
different treatments, and you need to find the way that is good for you. And here I think for some people, they are not able to do enough of exercise, for example, and then or the more heavy exercise that might be needed for
Yeah.
to really improve insulin sensitivity.
Yeah.
But it might also be that you do not need to do that heavy exercise.
Yeah.
Yoga is one. Yeah, low frequency electroacupuncture is one.
Yeah.
I think even cognitive behavioral therapy, because stress is another factor that
Yeah.
also may affect
Yeah.
the insulin
Yeah.
sensitivity. Mm.
Behavioral therapy, I think, would go a long way because many of them have eating disorders and
Yeah.
sleep
Mm.
disorders and
Yeah.
so many things that contribute to the stress.
Mm. Yes. Yes.
Yeah, so this was a fabulous discussion we had. I think I have covered almost all the questions that people asked.
Yeah.
Um, Okay, so Dr. Shobna is asking, very often we see that with treatment for lipid abnormalities, dyslipidemias, it improves the triglycerides and the other cholesterol, but usually does not increase the HDL levels. It decreases the triglyceride and
Mm.
other bad cholesterol,
Mm.
usually does not increase the HDL. Is that
Yeah.
correct? And is there a way we can target the HDL?
A very good question, and I have no good answer, honestly. And I don't really know why, because I think that is nothing that is specific for India or your population. I think that is a relatively common problem,
Problem.
and I do not have any good answer. But we know that, for example, again, lifestyle management like exercise and diet can improve it. So I think we need to boost that, and we need to create a program that is multidimensional, not just exercise, not just diet, and not just acupuncture. They can
Yeah,
have like a lifestyle, so they can select and go in and out in different types. Mm.
yeah, yeah, absolutely.
Mm.
So I think that was great talking to
Yes,
you.
nice discussion.
Learned all new stuff. I mean about insulin resistance. I think we can now. I don't think there are any more questions.
Okay, so it was really nice
It was really
seeing
nice.
you.
Yeah,
Yeah,
yeah. I
thank you very
hope to
much,
have you over another time
for sure.
to
Mhm.
discuss another aspect of your research.
Yes,
Thank you.
there's plenty of aspects.
Yeah,
We
see
are
that.
right now studying very much the transgenerational effects
Yeah,
of
and
PCOS.
there's a lot to understand about the epigenetics also.
Yes,
As
that goes hand in
clinicians,
hand.
we simply fail to understand. Like we think that maybe you researchers will find a candidate gene or something like that, and that will explain why people get PCOS or why they
Yeah.
get insulin resistance. But it's not going to come that easily.
Not really.
Yeah,
It's not that easy.
yeah,
It might explain quite a big part, but not all.
yeah.
Unfortunately, there is no easy solution.
Exactly, exactly.
No. Mm. So
So
it was
thank
really
you
nice
very
to
much
meet you.
once again. Thank you so
Yeah.
much. It was lovely.
Thank you.
Thank
Lovely.
you. Bye
Bye
bye.
bye.
In and watching our webinar on behalf of PCOS Society. We would like to thank Monash University for these lovely interactive webinars that we are going through this year under the leadership of Dr. Guru Shah and the PCOS Society. We would also like to thank USV for giving us the support for these webinars and look forward to the next webinar from the PCOS Society, which is the International PCOS Guidelines on 11th of July. and we'll have an eminent speaker, Dr. Claire Boothroyd, uh, for this webinar along with Dr. Gurusha. So let's look forward to that. Thank you very much once again. Goodbye and good night.